My name's Trevor Shipman. I'm Vice Chair at UHN. This is a joint webinar with NHFT, who I did many years ago work for, and KGH and NGH, that is UHN. I chair the veterans group at UHN. I think it was a case of trying to ensure that we were trying to get our message across to staff and also to patients, that we are part and parcel of that wider community, and you'll hear more of that as we go through. I will pass over to Morgan.
Thanks, Trevor. Good evening, everybody. It's really lovely to be here. Thanks for coming this evening to hear about this important topic. So, my name is Morgan Price. I am Director of Transformation within Northamptonshire Healthcare Foundation Trust. I'm the Trust Lead for Veterans, and I'm just going to be talking a little bit about the Armed Forces Covenant and what it means to us in the NHS. So the Armed Forces Covenant really came about through partnership between the Ministry of Defence, the UK government, private sector organisations, and a number of charities. And at its core, what it really is a declaration of respect for those who have served in the armed forces and their families, as well as a promise to treat those individuals fairly. So what the Covenant really recognises is that members of the armed forces community have unique aspects to their lifestyles. These can often involve things like frequent house moves, separation from support networks, and sometimes when transitioning from the military to civilian life, there can be an unfamiliarity with that civilian life. And all of these things can make it challenging to access public services. The Covenant is essentially a commitment to uphold two fundamental principles. The first principle is that the armed forces community should not be disadvantaged because of their service. And the second principle is that special provision may be justified in some circumstances. And really, this is captured under a legal duty called due regard. And this legal duty came into force in November 2022. To have due regard means to consciously consider the unique obligations and sacrifices made by members of the armed forces community. And that is our legal duty whenever we are delivering care. It does not necessarily mean that any particular clinical conclusions should be drawn, but just that it is appropriate to pay conscious attention to those covenant principles when making decisions around a range of factors. Who are we referring to when we are referring to the armed forces community? So under the statutory guidance, the armed forces community within the covenant falls into four groups. There are regular and reserve forces of the Navy, Army and Royal Air Force. There is British Overseas Territories forces when subject to UK service. It includes veterans and also relevant family members of any of the above groups. And by relevant family members, what we mean is spouses, civil partners, children, relatives who are part of the same household, financially dependent, or who have a carer responsibility for the individual. In terms of the demographics, the 2021 census shows that Northamptonshire has a population of roughly 803,000 people, and that about just over 25,000 of them are either regular or reserve members of the armed forces, relatively equally split north and west, slightly more in the north, and then obviously those families on top of that. So there are a number of NHS-led services that have been specifically commissioned to support veterans, service leavers and reservists in England. It's great we're going to hear today from representatives of Op Courage, and this is the service which really focuses on mental health and well-being. Meanwhile, there is Op Restore, which focuses on physical health and well-being. for veteran service leavers and non-mobilised reservists. And then we've got OpNova, which is specific support for veterans in the justice system. And what all of these services do is work with these individuals to help and support identify issues, to navigate to the best service to meet those people's needs, and to support with accessing wider or more holistic support, such as housing support. So just in the remaining time, we just wanted to focus a little bit on some of the work that has been taking place across University Hospitals Northampton and NHFT under this covenant. The first set of examples are really around support for people who've been transitioning from military service to civilian service. And here there is something in the covenant which says that if an applicant from a former armed service role meets the essential criteria for the NHS role that they're applying for, that they should be guaranteed an interview. And that's been put in place in UHN, and we're currently reviewing our policies in NHFT to put the same thing in place here. UHN also, there's something within the NHS whereby the years of service spent working in the NHS is taken into account when you apply for a new NHS job, and this then has an impact on which of the pay scales you start your new role in. And UHN considers the same periods of employment within His Majesty's Armed Forces as counting towards that aggregated service. I mentioned that one of the principles was around removing disadvantages, and there is a number of things that are being done here. So UHN provides support for reservists and cadet forces adult volunteers to help them balance their civilian and military responsibilities. NHFT runs an initiative called Step Into Health, and what this does is it connects with armed forces members in the community and helps access to training or placements, information about insight days, and also application support to help provide a career pathway into the NHS. This is a really interesting one. So this is quite new. This is something called the National Armed Forces Healthcare Training and Education Programme. It's been getting developed centrally by NHS England for some time, but it was formally launched very recently, 4 days ago. And what this provides is a regional training team for every region of the country who can come and help equip the NHS workforce with the knowledge and understanding of the barriers that our armed forces community faces, and also some really key insights into what reasonable adjustments could be put in place that would really make all the difference to somebody's experience of care with us. So that is being rolled out as we speak. There is a veterans breakfast that takes place. It's open to all veterans and cadets in the local community, and that's held monthly within Kettering General Hospital. Our organisation's websites reference links to organisations and charities that support the armed forces community across the system. And in both organisations, we have armed forces champions, and these are really crucial parts of the workforce. So if somebody had a member of the armed forces community on their caseload that they were concerned about, they could reach out to their armed forces champion, help get some advice and support, get some information about where they might be able to signpost or facilitate a referral to make sure that that person's experience of care was as good as we could get it. So I hope that provides a little bit of information about the Armed Forces Covenant and a bit of a sense of what we've been doing so far to work to it. I'm going to hand over to David Harrison now to tell us a bit about his experience as an NHS staff member and transition to civilian life. Thank you.
Well, thanks very much for the introduction. I'm just going to spend 5 minutes of your time, and then I'm going to hand over to Julie just to give an insight from her side. So transitioning for myself, I did 22 years in the military. I went from the rank of gunner all the way up to warrant officer class 2. Planning was important. Although I'd done 6 operational tours, I've gone through all these career changes. I kind of then left, and when I retired, if you like, and that door was closed, I kind of didn't know where to go. So if I just explain on the next slide what that kind of looks like there, was I kind of had these big things going on, the fear. I didn't know what life would look like. I had a wife, I had 2 children, but I didn't see myself as worthy. I'd lost all that within, I would say, a week or 2 of leaving. It was quite extraordinary what happened. I drank a lot. I had never looked after myself. I didn't feel like I belonged anywhere. I'd lost this belonging. I didn't understand the language that civilians were using around me. There was a lot of, like I said, you talk about logistics in a certain way where we might talk about buckshees and all this kind of stuff. It was all different language. Then there was the worry of things like medical, dental, that's kind of on the door in the military. It's there. I lost all understanding of what that was. So finding things like GPs, I just followed where my wife went, if you like. But my first experience of GPs, I didn't understand, once again, the language they spoke. So there was a lot of barriers there for me. My own values and standards had disappeared because I didn't see them when I was walking around civilian organizations applying for literally hundreds of jobs, but totally underselling myself. And in the space of what I call walking the wilderness for the first 12 months, I didn't know what to do. So I ran my own company, if you like. I got some help from the local council. I got some help from Royal British Legion at the time. They gave me some advice. But once again, I call it lost in the wilderness. And even my wife describes it as you didn't really find your feet for many years. And it took me a long time to do that. What I actually forgot was the key things that we talk about in the military: preparation. Prior preparation prevents poor planning and all that kind of stuff. But also I'd lost a vision and purpose. I'd lost my own self-worth. I'd lost a purpose in what I needed to do. So I went for a job in an industry which was a national training company, and I went for the lowest job that was there. I became this really bottom level, if you like, trainer. I started again. Within the first few months, the company saw something in me and promoted me to their training manager. Stayed there for about 4 years. We won national contracts. So once again, I was going, actually, I'm starting to find that I'm good at this. I should know this. These are the skills I've had before. And I feel like I needed a bit of belonging somewhere. But also, I still wasn't looking after myself as much around sort of like being disciplined with physical and mental well-being. So if I just look at the next slide, please, and what you can see on here was the things I'd forgot at my level. And it doesn't matter what level you leave the military with. We all have skills, and sometimes they don't come with great certificates. They come with a lot of experience. So I'd forgot that actually I was great at leadership. I was a people manager at a high level, and transforming that into like civilian speak, where when I left the military, you get a careers transition workshop, and they tell you how to build a CV and fill it full of military speak. And that became a bit of a barrier with a lot of organizations. When I then found a job, actually my wife found a job at NHFT, persuaded me to go for it. I then started to transfer my language and think, actually, what does this mean to me? So these are the key things that I'd forgot about, you can see on there. And on the next slide, just a few more bits of information, like around like training development, my background. And any soldier will tell you, male, female, whatever, is sometimes you have to do training on the hoof. So, you're bored, soldiers get bored on ranges or on exercise, and you get told to make an exercise, make a plan, make a lesson, map pocket lessons, if you like, in 5 minutes. And I forgot all these skills that link all through the key things I'm talking about there. But what was important to me when I came to NHFT, and if we just go to the final slide before I hand over to Julie, was actually, I might have all this stuff going on in my life, but on reflection, look how far I'd come. I'd come from nothing, if you like, hardly being able to read or write at the age of 19, to transitioning out at a warrant officer level. But I also work outside the organisation. I work for a company, which you can see there, doing trauma risk management. This is to spot the early onset of ASD, acute stress disorders, post-stress stress reactions, which I work with, where I take my leave about 12 days a year and go and work for them. Why do I do that? Sense of purpose. It gives me a sense of belonging, and that's important. And since I've been here in NHFT, their values meet mine: integrity, honesty, selfless commitment, all that stuff that I had in the military, I found in the NHS. And even though I'm non-clinical, I'm achieving because I'm taking a step every day. And even though I have my bad days, it's okay, because what do I do next? And I've had massive support from the NHS and NHFT. I've become a service user twice in my career here. And even though I've been only here 8 years, I've had that support at what I'd call management level, but also organizational level as well. And sometimes reflection, I forgot how far I've come. You know, I've been part of teams of all sorts of makes up, shapes and sizes. And yet every day when I get up, I think of that quote down the bottom. I've got a chance and a choice, not just to make a difference to other people's lives, but to make a difference to mine. But sometimes finding out what is out there, things like Op Courage, Combat Stress, I'm wearing that tie now, SAFA, Royal British Legion, even the Army website now has a great place on there around veterans. And I think it's called Hard Track or Hard Fast or something as an acronym on there. But there's more support if we look for it. But I'm going to hand over to Julie, who's going to talk a bit about hers, and then she'll hand over to the next presenter. But thanks very much for listening. I appreciate your time. Nice to meet you all.
Hello, for those that don't know me, I'm Julie Melvin, and I'm a palliative care nurse specialist in Northampton General Hospital. I've worked there now for 23 years. Originally a sailor's daughter, married a soldier, much to my dad's disgust. And my story really is about where I've come on a journey. I'm not the veteran, I was married to the veteran. And I just found through my journey, although it's a long time ago and it's progressed, I've got a passion to support veterans, and that's really why I wanted to talk today. When my husband left the army, I was working in Northampton General, and things were failing and things were falling apart. And I feel like if I hadn't have been a nurse, I was his voice. And it was me that went finding out these things. So something like it's happening today fills my heart with joy. But it's being mindful that we've got veterans in the NHS, but we've also got veterans' wife, and they're trying and negate this journey. I've got 2 daughters that have both successfully been to university, but the journey to get where they were was hard fought. And I'm hoping through things like this that things are going to improve. We can't forget that it's the veteran, but there's a ripple effect, and that's what I like to call it. It's not just that person, it's the family surrounding them. So we've got veterans in the trust, but we've also got veterans' wives in the trust, husbands, whatever. But I found my way through combat stress. My husband was treated by them. But as the journey went on, the system was failing really, because there wasn't anybody out there. And that's my thing to say today, is we need to make sure that people don't fall through the system. I've been part of the Armed Forces group in Northampton General Hospital since it started. And I also belong to the British Legion locally in supporting veterans in my immediate area. My husband sadly became very unwell, and I'm just going to, sorry, somebody's calling me. My husband did become very unwell, and we separated. And sadly, he lost his life 6 years ago. It was correlated in combat in post-traumatic stress, leading to addictions and things. But it's also still now my daughter's having to live with that. We found some support, we found help. But I've spoken at a conference last year in Birmingham, and it was talking about that ripple effect, and we can't forget that. So as trusts, I please say, don't forget that some of your workforce are wives, husbands, and they've got children that have had to go through this system. So I've not really got a lot more to say, but I just wanted to say that actually it's not just about the veteran, it's about our members of staff, that people don't know that they're seeing their husbands through a detox at home. And encouraging people that are in the veteran community to be able to speak freely, including the members of staff that are veterans' wives and husbands. So I've not really got a lot more to say, but I do enjoy being part of the Armed Forces network in the trust, And I'm so pleased this webinar is taking place, and we're becoming more aware of what's going on. So thank you. And the next speaker is Emma.
Thank you, Julie. So I've got myself, I'm the manager of the therapy service at St Andrews, Op Courage East Midlands, and I've got Georgina with me to help support the presentation today. So she's our clinical lead, consultant psychologist. So nice to meet you all. So we were recommissioned in 2023. We cover a large geographical area. So at the moment, St Andrews holds 2 contracts, so Midlands and East of England. Specifically going to talk about the Midlands today just because of the geographical area, and we're obviously based in Northamptonshire. So we're an integrated pathway model, so we work in unison with other services. And I suppose the key thing for us, and maybe one of the barriers that we face, is we're not an addition to primary services, we're an add-on. So a lot of our work is joint working. So a lot of people that we work with currently are also open to CMHTs. So it's really good for us to get the word out about our service and people actually knowing who we are and what we offer as our delivery. So our referral criteria is anyone who served at least 1 day in the armed forces and is registered to a GP. So it's quite a simple criteria. So most people can access our service. So again, we mentioned before about we're a partnership, so we work in unison with other services. So work closely with Lincolnshire Partnership. Obviously we're St Andrews, so we're specifically the therapy pathway, which I'll go into a little bit more, but we're kind of at the end of someone's already been triaged and gone through maybe multiple interventions, and then they come to us for kind of that more complex, intense support. And then obviously these are some of the other organisations. So Julie also mentioned previously, which was probably good timing, about the support for loved ones, families and carers of those who have served, which is really important. And Ripple Pond is an organisation that we work really closely with that do offer support for family and loved ones.
It's interesting because you use the word ripple as well.
Yeah,
yeah. So I was
really
thinking, oh, that's perfect for Ripple Pond. There you go. So thank you.
Really good time. We didn't plan that, I promise.
Yeah.
But yeah, a lot of their support is online, but I cannot commend them enough. They do a lot of work, and they work with a lot of service users, families that we have with it open into our pathway. And again, obviously Tom Harrison House focusing kind of substance misuse, alcohol dependency, and again walking with the wounded, another part of our treatment umbrella, mainly offering kind of that sort of kind of bespoke 12-session therapy, but again another great organisation. And again, this is some of the charities that we already focus on, but we work closely with other organisations. So yes, they might not be part of the integral part of Op Courage Partnership. We still do work closely with these organisations that do offer a lot of other things alongside us. So obviously RBL, combat stress, you would have heard a lot of these things before, but they're still under the same umbrella of Op Courage. And again, this is just a nice little map of the area we cover. So we do cover quite a large base. And I suppose one of the things that we do come up, Chris, when I mentioned about being not a substitute, but like an add-on, is sometimes when one of the main things is actually we're not necessarily like a crisis intervention service. So we do cover such a large geographical area. So I work currently with some people that live in Lincoln or Derbyshire. So we're not always on the floors. We do try and sometimes meet people or travel for therapy. But obviously, yeah, we cover such a large geographical area. It's not always possible. But just give you a bit of a snapshot of that. Yeah, so this is just a little bit about our service model before I talk a little bit more about our part of the pathway. So anyone can refer themselves in. So a veteran can refer themselves, a GP refer, a loved one can self-refer, and they would phone Mental Health Matters, which is a support line, and there's also an email to be able to refer themselves. So the model is when someone comes through and they get triaged, they get assessed by the urgent, non-urgent pathway. The names are pretty clear on the tin. They are trying to think about renaming it. But I suppose urgent is more like more intense support, maybe having housing difficulties, substance misuse difficulties, needing that more, I suppose, feet on the ground support at that time during the assessment. And again, the non-urgent is still have additional needs, but might not be as forthcoming at the moment. So then someone comes through, they have an assessment, they have a care plan, and obviously can get referrals to any other service that are like identified as appropriate. So we focus on MDT approach, so we're thinking about someone's holistic needs, thinking about other areas of concern. Maybe they need support with housing, maybe they have some ongoing health concerns. So sometimes it's about linking in with other services, but also thinking about what we can offer as Up Courage. So Julie touched on earlier about the importance of family support. So again, thinking into Ripple Pond, is there any carer support we need to think about? And I suppose from our part of the pathway, when someone comes through to us, they might have already had interventions from Walking with the Wounded or Help for Heroes, and maybe the therapies haven't been effective, or they're kind of we love that word complex, but they've have multiple traumas and maybe have been through things that haven't, like therapies that haven't necessarily worked. So that's kind of when they come through to us at St Andrews, and we have an eclectic bunch of professionals. So we have a range of psychologists, psychological therapists that specialise in kind of sensory motor therapy, EMDR, CBT, so different modalities dependent on the service user's need, and try and really focus on what's important for them. And again, this is just a little bit of a information about the service delivery. So obviously we are open 9 to 5. There is some flexibility on that. So even though, for example, our service is 9 to 5 for therapy, those individuals that might have, obviously people work, people have busy lives. So for example, Walking with the Wounded do offer therapy sessions at weekends or outside of working hours. So there always is something to kind of fit service users' needs dependent on what they need at the time. And again, we have that mental health matters support line for people that might need help outside of our working hours. And again, just thinking about Tom Harrison House, that is a residential support service. And again, this is the information of referral information. So this is again for the East Midlands. What I'd say is Mental Health Matters are absolutely amazing. They're really good at getting back to people quite quickly. They have a quite quick turnaround for their KPI. I think it's within a couple of days of getting a response. And generally people do get assessed quite quickly as well. Again, it's just got the information line there for the emotional support line, and again the website for Up Courage East Midlands. But like I said, we do obviously cover East of England as well, so obviously all that information is online, but this specifically for East Midlands. And I suppose I'm going to tag team this a little bit with Georgina, because she might be a little bit better to explain these bits than me. But I suppose just thinking some of the things that we need to consider with working with veterans. I think Dave already mentioned a couple of the things, but thinking about that military culture and that transition from civil to civilian life, and that being a really difficult moment, having something that was the norm to kind of transitioning can be really, really challenging, and making sure that people have the support when they need it. And again, thinking about, I think even the basics that we find in our service is do what you say you're going to do, be on time, be punctual, but be direct as well about what you're able to deliver for service users. And again, thinking about the importance of moral injury and what time of year. So in particular, in November, bonfire night, Remembrance Day, all those things can be a really difficult time for a lot of those that we work with, and thinking about what they need to support them during this time. Is there anything else from your perspective, Georgina, that
We think it depends, but some people have quite difficult relationships with services, and the way that they might have been discharged out of services can be actually quite traumatic, depending on their particular experiences. So we sometimes have a reticence about working again with big organisations, and how do we build up that trust. But yeah, I think you've picked up, obviously you mentioned the drinking culture as well, which unfortunately does impact on sometimes ability to engage. So we're always thinking about the barriers that people might come with to be able to engage meaningfully with our service, and that's why we try and take as much time as we can to work with people to build up that trust, so that people feel able to trust the service and work with us to get positive outcomes.
Yeah, I think that's it. That's a bit of a whistle-stop story of Up Courage, and obviously part of our therapy pathway, but I hope that was helpful.